Executing a reproducible pediatric higher mental function exam at the bedside requires strict structural precision and a systematic approach to the child's neuroanatomy. This framework maps the central nervous system exam into three distinct pillars. Our objective is the second pillar, higher mental functions. Clinicians often compromise this evaluation by attempting to test complex cortical thought processes before establishing the biological prerequisites. To prevent this, we apply the state before channel rule, distinguishing baseline physiological arousal from localized cognitive processing. If a patient isn't sufficiently alert, we cannot accurately measure their brain's response. The state must be confirmed intact before any channel is testable. We build the pediatric cognitive exam from the ground up, starting at the brainstem and moving vertically to the cortex. Adhering strictly to this hierarchical assessment ensures clinicians do not overlook focal deficits that are often masked by developmental variations in children. The examination begins by assessing consciousness at the level of the brainstem. This matrix separates wakefulness, a physiological drive managed by the reticular activating system, from awareness, which requires global cortical function. We quantify this baseline state using specific pediatric coma scales, the Adelaide scale for children under 5, and the Glasgow scale for those over 5. Once basic arousal is confirmed, we move up the hierarchy to test the first active cognitive process, attention. Attention serves as the load-bearing pillar for the entire cognitive architecture. Higher testing cannot proceed if this foundation is unstable. The primary clinical mechanism for evaluating pediatric attention is the digit span test. A 6-year-old child is expected to successfully repeat 5 digits forward and 3 digits backward. By age 10, normal development requires the child to repeat 6 digits forward and 4 backward. If the child fails the age-appropriate attention test, the cognitive portion of the exam stops immediately. Without attention, any subsequent testing of memory or language will lead to incorrect localization of the deficit. With the foundational state secured, we test specific cortical domains. Orientation testing evaluates a child's grasp of 3 domains: person, place, and time. In a compromised patient, these fade in a consistent sequence. Time is lost first, followed by place, and finally person. Next, we evaluate the fund of information to establish a baseline for the child's intelligence and their awareness of the world around them. This comparison isolates regional testing for the frontal and parietal lobes. Calculation serves as a dual-function test, measuring both working memory and parietal lobe integrity. We use story-based math for pediatrics to ensure we are testing logic rather than rote memorization. For example, asking how many days of work it takes to earn a specific sum. Abstract thought is the primary indicator of frontal lobe synthesis. We evaluate this through analogies, asking the child to describe how a table's leg is similar to a car's tire. These conversational prompts are actually calibrated stress tests designed to isolate specific cortical lobes. Memory is not a single unified function, but a multi-stage anatomical process. This model maps memory formation to 3 distinct anatomical stages. Step 1 is immediate or working memory. This operates in the prefrontal cortex and functions as the brain's filing clerk. We test this stage by having the child repeat 3 unrelated objects immediately. Step 2 is short-term or recent memory. The medial temporal lobe acts as the temporary cabinet. To test this, the clinician requires the child to recall those same 3 objects exactly 10 minutes later. Step 3 is long-term or remote memory. This utilizes the neocortex as the deep archive. Testing this final stage involves retrieving established past events, such as naming a current class teacher. Separating these recall tests allows the clinician to pinpoint exactly where the breakdown occurs along the memory pathway. Language evaluation focuses on the perisylvian network. It is a complex cortical process, distinct from speech, which is merely mechanical vocal output. As we can see, there are 7 testable dimensions to language processing. To identify speech pathology, we isolate the 3 most critical components within this matrix. Fluency, managed by the inferior frontal gyrus, is tested using timed animal naming. Comprehension, managed by the superior temporal gyrus, is tested through semantic commands, like pointing to a light source. Repetition travels the arcuate fasciculus and is evaluated by having the child echo complex phrases. We complete the exam with physical checks for naming, using pocket objects, and articulation, using the Pa-Ta-Ka test. By isolating fluency, comprehension, and repetition, clinicians can map a language deficit to a precise cortical lesion. These individual components combine into a single, comprehensive evaluation for use at the bedside. This systematic protocol is summarized by the mnemonic COMA-PI-FACT. This covers consciousness, orientation, memory, abstract thought, and perception. The remainder secures insight, fund of information, attention, calculation, and thoughts. The entire protocol is contingent on the verified state of the patient before the specific channels are tested. Following this hierarchy provides a pathway to move from clinical observation to precise anatomical localization at the bedside.